Okay, ma'am. So we are live now, and with all your permission, we are starting the session. And I am keeping everyone on mute for the time being to avoid any kind of audio issues. While you are talking, you can unmute from your end.
Recording.
A very good evening and a warm welcome to one and all present here in this Clinet session. I am Debolina from Clinet. We are very much proud to be a part of this webinar as a digital partner. As you all know, Clinet is India's largest live digital CME and doctors-generated medical content platform, which is exclusively free for all the medical practitioners. So now with all of you, I'm going to share a short glimpse of Clinet. Thank you so much, all the doctors, for your patience. Our website is www.clinet.com. There we have lots of live sessions conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors only. That also you can read. Beside that, we have polls and quiz also on our platform that you can play in your leisure time. So now, without further delay, I'd like to hand over the session to Dr. Nehal Patel, ma'am, to start with our today's program. Over to you, ma'am. Kindly unmute, ma'am.
Hi, good evening all. I would like to thank our AOPG President Dr. Rakesh sir and Secretary Dr. Kirit sir for continuing this program. I would like to invite Dr. Yogesh Parikh sir, who is past President of AOPG and founder of this project of eGurukul. Sir, please say some few words.
Madam, continue. Madam, continue.
Yeah, okay.
Okay.
Thank you, sir. So for today's session, we have presenter Anna. She is a third-year resident from Government Medical College, Surat, and as her guide and mentor, Dr. Vijay Shah sir, who is medical director at Nirmal Hospital, and he is a retired professor and head of Government Medical College, Surat. Sir has many things in his whole of the life, and he is a superb teacher throughout the career. Sir, welcome. We have two experts here. Dr. Vinu ma'am, she is DNB super specialty in medical genetics, and she is consultant in medical genetics at Center of Human Genetics at Bangalore. Her special training was in course of human genetics at Jackson Laboratory, Bar Harbor, Maine. She has many publications in books, and she has authored the textbook also. Welcome, Reenu ma'am. I also invite Dr. Sonal Shah madam. Sonal Shah madam is additional professor at MP Shah Medical College, Jamnagar, and she has experience of around 25 years for teaching in pediatrics, and she has her keen interest in the field of pediatrics neurology, and she is running the pediatric neurology clinic at Jamnagar since 20 years. Through our whole of the program, we have the blessing of Dr. Baldev Prajapati sir as a convener of this program. Sir is a renowned teacher, and any words I say will be few for him. So let's start with this, and I'm giving this platform to Anna and Sir Baldev sir.
I think before Dr. Anna starts, good evening, friends.
Good evening.
Nice to see all of you on this platform. That how we are going to have this session, what will be the flow. As already Dr. Nehal said, Dr. Anna is going to present the case. I think she will start with the history part. You know that on this platform, the discussion will be in different form compared to the classroom, because we'll not be able to see the patient, we'll not be able to have the one-to-one interactions on each particular complaint or symptoms. So I think first she will give us the account of the history part. After the history, I think she will stop sharing, and then we'll start with this basic whatever the symptom problems analysis. Meanwhile, I will say the experts can also have the inputs at the end. Unfortunately, we have only one, I will say, person to interact, but we wish the multiple students on the platform so that we can have these live interactions with more students. I think, Anna, you might have invited your friends on this, I would say, panelist link. They can join with us and they can have I would say, their
Yes.
own interactions. Still, I think you can do. The very close friends, you can request them to join. I'm sure that this person will help for the panelist link. The reason is, that as we have the more interactions, more discussions, we learn more. All of us are going to learn more. So I think with that, I welcome the experts, Dr. Vijay and everybody. And with that, I request Dr. Anna to share her PPT and start the history part.
Hello. Good evening, all. I hope I'm audible. First of all, I am so happy I got this opportunity. Thanks a lot to Yogesh sir and especially Dr. Yogesh who has given me this opportunity. And I cannot explain my gratitude to my mentor, Dr. Vijay sir, who was my PT guide. And I'm so happy that I have good experts for me. Hello.
Dr. Anna, there is some, I will say, issue of net at your end. You are not audible properly. You are not audible properly, please. Or otherwise, I think you can make your video off so
Hello.
that probably it may improve.
Am I audible right now?
Yeah, I think now better.
Okay, sir. So thank you so much for giving me this opportunity, especially AOP Gujarat Baldev sir and Yogesh Parikh sir for giving me this opportunity, and my mentor, Dr. Vijay sir, who has agreed to be my mentor again despite of having such a busy schedule. And I'm so happy that I have such esteemed experts to guide me through this case presentation. So, shall I start sharing the screen?
Yes.
I hope it's visible right now. Hello.
Yes, slightly see that you are audible. Please carry on.
Okay, I'm sorry. I'm presenting the case of a patient named Hariom, 5-year-old male child, was brought from Pandasara, Surat by his mother, a reliable informant, with the complaints of the following things. First, the child was having difficulty in catching up with his peers, running and games, weakness of lower limbs starting from 1 year back. There is history of recurrent falls during games and later even on walking fast since last 4 to 5 months. The mother noticed difficulty in getting up from sitting position without support since last 2 to 3 months, and there is difficulty in lifting heavy objects by bilateral upper limb since last 2 to 3 months. There is no history of any tightening of any of the forelimbs. There is no asymmetry in the weakness. There is no loss of sensation or tingling sensations. There is no diurnal variation of the weakness, and there is no association with any pain or any twitching of any muscles. No difficulty in combing, eating, or writing. No history of slippage of slippers from the foot. There is no history of any antecedent or concomitant fever. No history of antecedent or concomitant diarrhea, vomiting, or any fluid loss. No history of any suggestive toxin ingestion or inhalation, chronic or acute. No history of any constipation, cold intolerance, apathy, or somnolence. Antenatal history, mother is a 38-year-old female with a
I
height of
think
5 foot.
I think Dr. Na, before we go further, can you just stop sharing for a while?
Huh.
If it is possible, you can make a video on. Dr. Anna, can you make your video on?
Yes, I'm trying, sir. Huh.
Yeah. I think let us take from the first symptoms, whatever you have described. You said that the 5 years old male child, without sharing, are you able to speak from the first slide? Is it possible?
Yes. Hi, he is a 5-year-old male child. He presented with weakness of both lower limbs. He was not able to run or catch up with his peers while they are walking fast since last 1 year. It has slowly progressed, and
I
5 months back he was
think,
not able to walk fast.
sorry, Dr. Anna. How will you interpret that complaint what the mother made? What does it indicate? I think, as you said, mother
It can
indicates
be
that since 1 year, child is having the problem of the weakness of the lower limbs. And in what way she has interpreted the weakness?
she interpreted it as generalized lethargy, and she had taken the patient to a local clinic where he was given multivitamin supplements, thinking it was dyspnea on exertion, या फिर it's lethargy, simple lethargy or malnutrition. But there is no signs of, there is nothing indicating malnutrition in that patient.
No, how will you take it?
Next,
Suppose the child is brought to you on the very first day with this complaint. How you will take it? Will you follow my question?
I first.
Suppose this child
Somebody
was brought to you from the beginning. You are sitting in your OPD and
1 year back.
mother complains in this way, then how you will interpret? What will be your thought process?
My thought process will go about exercise intolerance exertion. But there is no expert, it can exercise. I will check anemia.
I think is there a possibility to improve your net? Because your voice is frequently breaking. Or I think you are sharing from the laptop. Dr. Anna? Okay, if it is not possible, you can carry on.
Hi, yes, Ranch.
Okay, I think without video you can, so that at least there will be some improvement in your voice.
Okay, sir.
What I was asking you, that suppose you are sitting in your OPD and with this complaint child is brought to you, what would be your thought process? Or what other things you will ask the mother to clarify some issues?
Dietary intake should be checked on, and we should also check about whether the weakness is having any diurnal variation, like is it
Okay.
present in the and we should also check about the check about pallor, and like my
Okay.
first DD will be anemia, and
Right.
then also and I should check the nutritional status of the baby, whether there is SAM patient, whether it's SAM severe thinness, as it we have to rule out all that, and if all
I
that
think
is ruled out, next.
some will be quite obvious.
Yes, sir.
Right. Just looking at the child you can say.
Yes.
Suppose here all these features are not there. Then what will be your thought process?
inactivity, I will ask her about whether the patient is generally inactive, or only during exercise is the issue. If the
Okay.
child is generally inactive, we have to go for thyroid profile. It can, but in males, it is less likely. We'll have to go for thyroid profile, and we have to check CBC to again rule out anemia. And
Please, Dr. Anna, in the exam also, what the examiner is interested that discuss these, whatever the information is available to you from the history, right? That means examiner wants to know that how we are able to analyze the symptom, the complaint of the mother. I think what you said is right, that any such these type of the complaints from the mother or the child, you will consider that this is it really due to the anemia? It is very common. Absolutely, you are right. But suppose anemia is there, then how the child will present? Or suppose beyond that, what other points you will ask so that you become the more clear? Anyway, another thing you complain that recurrent falls.
yes, sir.
Can you enumerate some conditions where the child may present with a complaint of the recurrent falls? Not necessarily our case. Generalize, you can talk.
Recurrent falls can be due to, sir, it can be CNS issue
Okay. What
in
are the
which we have all the element
what,
lesions.
what are the CNS issues?
It can be LMN lesions or UMN lesions. In
Okay.
LMN, we have neuropathy and myopathy mainly because it's a chronic thing. It is not an acute thing. It has been there for 1 year. It is a chronic thing. So it can be neuropathies uh, and it can be myopathies, muscular dystrophy.
Why the child with the neuropathy will be the frequent falls?
If the patient is having high stepping gait and with the high stepping gait, the child is trying to run, there is a chance there is.
Okay. Doctor, now always try to think very simply. Right. That suppose child is sitting, you are sitting in the OPD and complains of the frequent falls. The first you will try to see that what is the age of the child. Maybe sometimes physiological. Right.
Yes, I think so.
From that you will start that if the child is having some problems of balance or the problem of some muscles or this that muscles again, as you were thinking, is it really the stiffness of muscles or really some weakness of the muscles? And that weakness of the muscles again, as you were describing, that you can analyze it is really some peripheral neuropathy problem or some other reason or something like that. You know, in a case of cerebral palsy, that is very obviously that most of the times the complaint of the frequent falls. But from that, you can say that the stiffness will be quite obvious, right? In a case of, the cerebral problem, the cerebral ataxia, even frequent falls is going to be there.
Mm.
Even the Paediatrics ataxia, with the ataxia in short, frequent falls is common. Or again, even due to some toxin also, this is possible. Right? And if you are thinking for neurological problem, then you will go in the details. Right? That it is exactly what you are thinking, upper motor, lower motor. Lower motor, again, you may go in the details. But here now, gradually, if you go to the third complaint, what I noted, the difficulty getting up. What does it indicate? How will you take it? How will you analyze this symptom?
It is axial muscle or girdle muscle weakness that they're talking about. Patient and mother typically describes that he climbs upon himself to get up from the sitting position. So that typically describes proximal muscle, girdle muscle weakness.
Again, if I just draw your attention, the focus on the complaint what mother had complained will not mix up. Right? I think rolling over maybe the next problem also. Any, I will say, person complains of that finding the difficulty in getting up. Even adults also. Suppose the lower height sofa, to be very frank, gradually sometimes now I am also finding the difficulty in getting up.
It may
Not
be
so,
because of pain also somewhere.
yeah, not so easy even.
Mm.
So you know that always what is our idea, that go for the simple thought process, analysis of the complaint, not exactly the etiology, and from the beginning nobody knows the etiology, right? But what I mean to say, that suppose any person or any child complains of that he is finding difficulty in getting up. After getting up, he is able to walk and everything. So that exactly what you were talking, that something is wrong with the proximal muscles weakness.
Proximal muscles.
And particularly the proximal muscle weakness, that if you are finding difficulty getting up, probably hip muscles, right? And that can be the commonly with some muscle weakness, and that is more with the myopathy. But at the same time, suppose child or the person is having the difficulty, particularly in, I will say, keeping these slippers in the foot, then what it can be?
Distal muscle weakness, sir. And distal
Yeah,
muscle
other
weakness
or
both.
what other, I will say, complaint which you are just mentioned, the negative, the difficulty in raising the upper extremities, combing the hairs, removing the, I will say, short. This indicates that probably with this upper extremity involvement and distal also, buttoning and buttoning. Very classical example for the upper extremities. So I think here now if you say the weakness, recurrent falls and difficulty in getting up, gradually is said that the difficulty in lifting the heavy objects. What does it indicate?
Weakness is progressing to upper limb also, sir.
Yeah,
Initially, upper limbs were okay. Now there is upper limb involvement.
right. So exactly what you were describing, that here is there is some problem which is of long duration, therefore the chronic. As you are describing that initially, what are the symptoms where they were progressive? So some chronic progressive neurological
Slowly.
problem with
Neuromuscular.
probably involvement of the muscles, especially the proximal muscles, is more likely. From this even complaint itself, you can try to derive. And you know, we always wish, I think not, it is not only for exam, even in the practice. If you go in this way, most of the times even rare disease you can get it. And later on, you have mentioned some negative points. Can you take one by one the negative points and what is its importance? Why you have asked these negative points, Dr.
Yes,
Anna?
sir. Ha, sir. Uh, First of all,
I think you may not share it. Okay, otherwise you can share, no problem. The only thing I want that there should not be disturbances when we are talking. Okay, you can take the previous slide.
This was my presenting
Yeah.
complaint. And then going into the negative history, there is no tightening of any limb. So spasticity as such is ruled out, and we can take it off the side. There is no tightening or abnormal movement. So UMN lesion
Okay.
is less likely.
Okay.
Next, it is asymmetry. There is no asymmetry in the weakness. Weakness is symmetrically present in both sides in all four limbs.
Right.
And then or pain. So neuropathy is also less likely because there is no sensory involvement of pain. Then there is no diurnal variation. So because nerve is not there, next our topography goes into neuromuscular junction where there is usually diurnal variation, because with increased exercise or increased usage of muscle, there is fatigue. So that is also not there. And there is no difficulty in eating, writing, or any distal muscle activity. For example, slippage of slippers from foot, unbuttoning, buttoning. There are no issues in the distal muscle activity. And there is no abnormal twitching or contraction of the muscles, which I actually meant to rule out myotonia or muscle fasciculation, fibrillation, etc. All those things are also absent in this kid.
Okay.
And then history of antecedent and concomitant fever. Actually, the importance of this comes in subacute or acute kind of weakness, where there is Guillain-Barré syndrome, where you have an antecedent like 2 to 3 weeks back, there is history of fever. that is not there. There is no history of any fever, and there is no fever right now also. Viral myositis can present with pain and weakness of muscles similarly, so that is also not there. And there is no history of any antecedent concomitant diarrhea, vomiting, fluid loss. There is nothing suggestive of electrolyte imbalance.
I think
There is no history of any
regarding
history suggestive.
sorry, Dr. Anna, for a minute. What you said, this fever, and you gave the illustrations, I think they are relevant to the problem of our patient.
No,
Do you
sir,
think
that
that
is
the,
like
do,
it is
do you think that this fever or the suppose some autoimmune disorder or GPS or something will be going on in this way for 1 year, 2 years like this?
no, sir. It is more in a subacute, yeah, acute muscle
Yeah.
involvement. Yeah, this
Similarly,
electrolyte involvement.
I will say diarrhea, vomiting, fluid loss will be the acute condition. It will not
That
present
also
in
acute.
this way. Some toxin, okay. Constipation, cold intolerance, what are your
Maybe
idea
it should
regarding
be
this?
chronic exposure to toxin.
Okay. Again,
Cold
justify.
intolerance, apathy.
Okay, finish it, please.
Sir, constipation. Yeah, this I have asked for a ruling of hypothyroidism, which
Okay.
can present with generalized weakness and apathy and all. So other symptoms pertaining to hypothyroidism is also not there. And when we go into the examination, we'll find one or two signs which somewhat can relate with hypothyroidism. So I wanted to rule out that too. For
Okay.
example, muscle hypertrophy and all. So I just wanted to rule that out too. So easily I asked for constipation, cold intolerance, apathy, somnolence, which is not present in this child. And it is less likely it's a male child of 5-year-old, 6-year-old age. So less likely to be hypothyroidism, but still I wanted to rule it out.
But it is likely in 5 years old child, hypothyroidism.
It would have presented earlier, sir, like with mental retardation, if it is a hypothyroidic, congenital hypothyroidism. And acquired hypothyroidism will not directly present with weakness. That too, which is progressing over 1 year. It should have presented earlier. And this
Okay.
is a male child, more common in female child.
Anyway, I think what was my idea? The negative point should be just, can you stop sharing?
Nice.
I think negative point should be relevant to our case. It should not be made generalized, which is given in the standard textbooks. I think related to the supposed complaints, whatever you are preparing the hypothesis, this is more likely the problem. Related to some very specific points, presence or absence will help you either to strengthen your possibility or to exclude. That is your idea.
Dr. Anna,
Or
yeah, yes, sir.
Or some differentials which you want to exclude.
Yeah, that's what I want.
Nearby.
So,
Or third, suppose some likely problems or complications in a given case that you can add. So relevant point should be included in this case. I think now, Dr. Sondal, you can take it.
yeah, Dr. Anna, have you asked the history of rashes? And
Yes,
why,
yes.
yes, and why you should ask about the history of rashes with the relevance of this case, gradually increasing weakness and all. Since you taken the history of hypothyroidism, rash, I think history of rashes and other things is more important. The nodules on the body or something like that. So can you pinpoint that? What is that?
Ma'am,
yeah.
Autoimmune conditions that can
so
result in dermatomyositis.
Yeah, dermatomyositis.
Yeah.
So that is usually they have progressive proximal muscle weakness, and there you have. So what will be the other things like rashes and other things? Usually
other autoimmune.
Yeah. What is Gottron's papules? That is you get.
Yeah. Do you have any idea, Dr. Anna, regarding this Gottron's papules? What madam asked you?
No, sir.
Yeah.
Okay. Yeah. So history of rashes is more relevant than I think history of hypothyroidism. And one more thing, like hypothyroidism, can present at 5 years of age with this
Yeah.
children. Yeah. And it is not like that. It is acquired hypothyroidism. Autoimmune is more common in female. Male children can have congenital hypothyroidism. Incidence is same in both male and female.
Yeah.
That's
So I think very good points, madam. Even dermatomyositis point of view, it is commonly present with the myopathy and may have this type of the complaints. But to exclude it, probably you may ask some other manifestations of the disease related to particularly the skin, rashes and other things. So this is very important. I think before we go further, let Dr. Vinu, would you like to add something from your side?
So essentially, right now, the history is more so focused on motor milestones. Probably as the journey goes through the differential diagnosis, probably we'll be able to discuss more about it. And apart from that, I think all the history suggestive of any infections, trauma, fracture, I think probably she negated it through the journey. So those differentials are out. So I think most of the points were covered so far. Yeah.
Right. Okay, Dr. Anna, you can share your PPT and go for further history part.
Coming into the past history, there is no history of any previous hospitalization of this child. There is no history of any fever with rash, and there is no history of any vaccine preventable disorders. Antenatal history: mother is 38-year-old female with height of 5 foot 2 inch and was registered pregnancy with 5 antenatal visit with good antenatal weight gain, and all the USGs were antenatal USGs were normal, proper iron folic supplementation is taken, and there is no positive history during the antenatal history. There is no history of any increased or decreased fetal movements during the pregnancy, no PIH, DDM, or smoking or alcohol intake. There is no history of any prolonged labor. Perinatal and postnatal history, it is a full-term normal delivery, hospital delivery, 2.5 kg baby weight. Child cried soon after birth and was given routine newborn care. There is no history of any NICU admission or neonatal jaundice. His clinical activity was taking BF well and was discharged on the 3rd day of life. Family history, there is no history of any consanguinity, no similar history in sibling. Actually, he has a elder sister. She is 8-year-old and she doesn't have any similar history. There is no history of any abortion or bad obstetric history in the mother. There is no similar history in any family members in both maternal and paternal homes. Developmental history: in the gross motor, the child learned as this much is what the mother remembers: sitting by 1 year, standing by one and a half years, walking by 2 years, and running by 3 years. Currently, he can climb stairs up and down in alternate feet and can run, but he cannot skip or hop. So it is 78% development, 75%. It is a 70% developmental quotient in this child in gross domain. Fine motor, pincer grasp achieved at 1 year, scribbling 1.5 year. Presently, he can write in Hindi properly and draw diagrams, simple diagrams. Language, he can talk in full sentences, say stories and poems right now. He's doing well with his peers. Social, good conversational skills, maintains eye contact. Scholastic performance is average and he has to do a lot of hard work to achieve the same. So it is an isolated gross motor domain, mild delay is present. Vaccination status, BCG scar is present, all the vaccinations has been taken at time and there is no, he's fully immunized. Diet history, he's a pure vegetarian and the calorie intake and protein intake is more than adequate. There is no significant deficits and there is no issue in feeding or eating by own or swallowing. So to summarize my history, I have a fully immunized 5-year-old male child with an uneventful birth, antenatal and past history. who was apparently normal till 5 years of age, except for an isolated mild delay in achieving gross motor milestones, and a poor scholastic performance, presenting with insidious onset of proximal muscle weakness with no sensory of fever, which progressed or crash, which progressed over last 10 months, affecting his daily activities.
Okay. I think as we don't have the other students to respond, we'll have to ask you only, Dr. Anna. Otherwise, others can assess you that whether they are finding any query or question to you. Because I think students are not there, we'll have to ask the questions to you.
Yes, sir.
You know, from your story, it becomes quite obvious to the examiner that you have the focused narration or the description. And you know, focus or this targeted description makes obvious that the person is aware regarding the details of the case. At least in the examination, I know that most of the students know the diagnosis. At least try to present that as if you are not aware of it. Because for any, I will say, consultant, suppose if I am presenting the case even, it becomes difficult for me to find out every positive and negative points in the history. But still, what was the regarding the head control? Did you ask the mother? If you have asked all other points, Dr. Anna, regarding the head control, was it at appropriate time? Was it normal even?
I didn't hear the last sentence.
Regarding the head control.
Head control.
Yes.
She said head control in and around 4 to 5 months. She was not specific. She was actually.
I think on her side there is problem of net also.
Not very sure about it. That's why I didn't write it in my history.
And I think your voice was,
your
connection was lost for some time. So probably we have not heard you. Can you repeat it?
So the mother was not sure about the achievement of head control. She said it was almost same as her elder daughter, which was about 4 to 5 months. She didn't. She said the child had a delay in walking and doing other things, but head control, she says it was almost normal. She didn't observe any delay in the early 1 year age after.
Right. Another point, you said that they fully vaccinated. Is it so in your patient? What do you mean by the fully vaccinated? Whether the child is given this pneumococcal vaccine? Whether the child is given the flu vaccine?
According to the universal schedule, he was.
Yeah, so what I mean to say, I think this is again common presentation by the students, or many times they say that the vaccinated for the age. But you know, whatever the schedule is used, you can say, I think once you say it's okay that as per the national immunization program or government program is given, then it's all right. What are the, suppose once you are thinking for this type of the condition, which vaccines are important for this child? Which probably positively one should take care.
Sir, this child is having a muscular issue which might progress into respiratory muscles and even swallowing muscles. Bulbar and pseudobulbar muscles can be involved. So there is risk of aspiration and pneumonia. So he should be given PCV. Encapsulated organisms should be ruled out. So pneumococcal vaccine, meningococcal vaccine should be taken care of in this.
But why the child is prone to develop this infection by the encapsulated organisms?
Not encapsulated, sir. Like for pneumonia and meningitis mainly pneumonia prevention. Aspiration pneumonia.
For the pneumonia, which vaccines you will target?
in this age groups are PCV meningococcal or hip H influenza is already provided in
But
UIP.
particularly in this season,
Influenza vaccine.
yeah, the flu vaccine. On the contrary, even in any challenge, particularly so in this type of children, many a times it may be the fatal complication if by chance suppose if it develops, right? So that you should. Second thing, for this again from the exam point of view, you know, any DQ, any quotient, it's a developmental quotient, IQ, intelligent quotient, any quotient is a plain figure. It's not the percentage. I think many books have also mentioned even, but you know, if you see the mathematics, mathematics point of view, it's a plain figure. Quotient is never in the percentage. Although we always go by the 100, and that's why probably that is very common mistake. But you know, IQ always what we say 60, 70, 100, but it's not in the percentage. Any quotient point of view, this is I will say just general knowledge point of view, but mathematics they say that any quotient is plain figure. So I think if you use even this, that will be more impressive that you are aware of this quotient also.
Okay.
So anyway, from the history now, what is your, I will say, interpretation, inference?
Sir, it is a pure motor weakness. That is my first interpretation because there is no pain or sensation loss. It's a pure motor weakness. And there is no tightening or spasticity or abnormal movements or any cortical involvements. So it is an LMN lesion. So in LMN, I have ruled up neural involvement and neuromuscular junction involvement. So
Why you say element? Even even the central problem also can present with the element.
Yes.
So how you, from the history only without examination of the patient,
no.
how you can make up your mind that this is element only? Can you give some example where even due to the central problem also lower motor neuron type of manifestation can develop? That means hypotonia, Recurrent Falls, even other points will be there. Can you give some examples?
There are conditions where there is involvement of CNS and muscles together, like myopathies, like congenital myopathies can present with CNS issues, central nervous system and peripheral nervous system together involvement, and juvenile ALS can also present. But in all that conditions, there can be tightening along with the more than hypotonia. There will be tightening. Hypertonia.
If I give the example, you know this hypotonic cerebral palsy,
Hypotonic cerebral palsy.
right? That can have this clinical picture will be like that. Just on examination, I may come to more details that DTR is exaggerated or something like that, or some other region small head is there, or something like that. I will say why not the Down syndrome? Down syndrome can have the similar manifestations.
But patient was asymptomatic till 5 years, sir. That's why I didn't consider.
Parents may not be aware of it. Parents may not be aware of it. Not necessarily. Down syndrome of a child is brought to me at the age of 5 years. It happens so. And the mother complains in this way only. That finding difficulty in walking, even frequent falls, even difficulty in getting up. Dr. Anna.
Yes, sir.
Why it is not, I will say, Down syndrome?
Sir, throughout the 5 years of age, he doesn't have any issues of, there is no global developmental delay. There is only isolated motor delay.
That's the point. One point, yes. Suppose if you focus on the development, that point is right. That in Down syndrome, if development is affected, it is expected that usually other domains will also be involved, not only motor. And suppose isolated, if you are thinking, I think that's a good point to catch. That isolated, more involvement of the motor milestone is indicating that there should be some problem of musculoskeletal issue.
Musculoskeletal issue.
And if you think for the musculoskeletal, more of the muscles,
Yes.
they're having the absence of other skeletal manifestations. And that may give the idea, right? So what was my point, that always try to think broadly, right? And here, suppose you know that now in the MD examination, DNB examination, it is routine that at the end of history, give the summary or your inference. And that should be in the very short 8 to 10 sentences. And that you should prepare the hypothesis, may not be the diagnosis from the history. But you can prepare some hypothesis that what is the likely problem with the child. So can you just try, attempt, give the summary in short, Dr. Adnan? I think again probably her connection is lost. Dr. Anna, are you there?
Sir, sir, it is
Yeah.
a 5-year-old male child with an uneventful. Hello, sir. Am I
Yes,
audible?
sir. Yes, yes. Now audible. Now audible.
Hello. Ha, sir. Hello, sir.
Please carry on.
I'm presenting the patient. Full birth, antenatal, and past history, apparently normal till 5 years, except for an isolated motor delay in the gross motor domain, and presenting with an insidious onset of proximal muscle weakness with no sensory loss or pain or fever or rash, with progressed over the last 10 months, affecting his daily activities. So it is a pure motor delay, probably a pure motor delay, and we'll have to go for the examination for which is chronic pure motor delay, sir.
Okay.
Chronic. Yes, sir.
Dr. Anna, can I just ask you a question? Probably
Yes,
at the end
yes,
of
sir.
history, rightfully, like what Sir mentioned, with this history, probably it'll be good if you think of conditions that manifest for the first time in a normal doing kid until 4 years of age with some sort of motor involvement, or neurological disorders that manifest for the first time 4 years onwards. So if you can recollect at least 2 or 3 disorders, probably that will be the best way forward in your examination. And you may be right, you may be wrong, that's fine. At least based on age of onset of symptomatology, could it be a male or female? Probably if you give 2 or 3 differential diagnoses. And after that, based on the sex predilection and with that particular age of involvement, you can probably narrow down your differential. So would you like to mention few differentials that present for the first time 4 years age onwards?
Ma'am, from 4 years of age, there are actually a lot. Even there are genetic conditions that can present. Mostly genetic conditions that can that will come at the first onset at the age of 4 to 5 years of age. It can be muscular dystrophies, as we are thinking about a muscular issue. So it can be muscular dystrophies, and mainly Duchenne's Becker can present at typical age 5 to 6 years of age group without any previous insult or previous issues, and no antenatal or immunological issues. And then there is also late onset myotonic dystrophy, which is myotonic dystrophy usually comes in a congenital form, but there is a very low percentage of which can manifest at a late point of age group also. And there is myopathies also, which can present in a late onset manner. In a juvenile onset myopathy is also present. And then if we are thinking about neuromuscular junction, again autoimmune kind of myasthenia gravis can present in late childhood or early adolescence. And then there is SMA. Spinomuscular atrophy can present with hypotonia. Usually, most commonly, it is congenital. Yeah, in the age group less than 1 year, yeah, less than 2 years. But there is type 3 SMA, which can be late onset, can come after 4 years of age. So these are the muscular conditions that can present in the same way with the late onset, 4 to 5 years age. After 4 to 5 years of age, muscular conditions. And
Essentially, it was a commendable effort indeed, but probably this requires a little bit of reshuffling of your differential diagnosis. Definitely, myotonic dystrophy, I'm sure Dr. Sonal madam will agree that usually the late onset ones are
Yeah,
adult
late
onset.
onset,
They're
usually.
not childhood onset. And congenital myotonic dystrophy, the neonatologist will come across these sort of cases quite common as floppy infant with central cause. And congenital myopathies right from beginning. That's why sir was asking you, did you ask when was the neck holding? When did the child sit down? When did he stand? When did he start walking? At every step, there would be some amount of delay by few months or whatever it is. So as far as what you have taken us through this journey is that he was doing plastic till 4 years or so, and then 1 year, since last 1 year, he started tripping off and falling off. Probably if I would be in your place, I would also take this opportunity to give differential diagnosis of where children fall down frequently. I may be wrong. Here, the problem is just like what Sir told, you know the diagnosis and you'll have to pretend as if you don't know the diagnosis. So here you need to give differentials where children fall down frequently from 4 years and age onwards. Would you like to mention at least one or two disorders? Ataxia telangiectasia. This is the age of onset. They start falling frequently. There comes your negative history, that whether he's able to walk in a straight line, does he sway around, does the eyeballs show abnormal movements, recent onset. So in your negative history, these sort of negations are very important. And then you have, and in your summary, you mentioned one statement, motor delay with poor scholastic performance. The word poor scholastic, I'm sure Dr. Sonal will agree with me. It reminds me of X-linked adrenoleukodystrophy. Given the fact that he's a 4-year-old boy and doing somewhat fantastic till about 3 or 4 years, and then he starts showing frequent falls. Like, I think the discussion has been whether it's a UMN, LMN. Rather than that, try to keep your thoughts quite broad so that you don't get stuck in your differentials. You have the luxury of taking it forward more and more so in the discussion. So when you stick to frequent falls, when you stick to poor scholastic performance, you can actually grab the examiner's attention and talk more and more. So again, X-linked adrenoleukodystrophy, but again, they'll have some deterioration, behavioral change, and so on and so forth.
Pigmentation, maybe.
Yeah, and then there are also SMA. SMA is actually a very common disorder, but as pediatricians, we get to see more so the infantile SMA more commonly. Yeah, but again, SMA can also manifest as childhood onset, which are the lesser severe variants, but they are quite uncommon. I'm sure Dr. Sonal will agree with
Yeah, but child had history of delayed walking. So he started walking. So there was some
can also be
point.
a good differential diagnosis.
And
then Wilson.
Yeah, you should have mentioned your developmental quotient as far as motor milestone is concerned. Before, he started developing symptoms since 1 year, before 1 year. So what was his DQ, whether he was doing well till before 1 year? And then what was the deterioration? So was there fall in DQ for the age at presently? So that you have to be very specific about it.
Yeah.
No, there is no regression or anything like that.
It's
but you say
mother is not specific.
He started having falls, initially was walking properly. Now he has started having falls and all. So that is definitely, he has lost some abilities, definitely.
So see, here the thing is, it's very important that you take history in detail. See, most of the time it happens that in our busy OPD, when a pediatrician sees around 30, 40, 50, 100 patients a day, they usually take developmental history not in a detail, because now people are tuned to take history, but like it should be a habit to take it in a detail. Right? Recently, before around 15 days or so, it had happened that in our OPD, we had one child with the same Duchenne muscular atrophy was referred to us from outside. And even the resident was sitting in front of us, he took the history, but he just said that the motor milestones are delayed. So it just said milestones are delayed. Actually, it was a motor milestone which were delayed. So, and then he said skull circumference, it was just on a borderline. Considering that, he gave the diagnosis that there is some CNS issue. So and then when history was taken in detail, we found out that there was a developmental dissociation. Like the motor milestones were definitely delayed, but the other milestones were normal, like his speech was normal. He was going to school, was normal at school, but the motor milestones were definitely delayed. And when then we examined, the diagnosis was absolutely clearer, muscular dystrophy. So it's very important, like one should give enough time to the patient. We have to take history in detail. We should take developmental history in detail, and we should use certain charts like that Trivandrum developmental scales with some Baroda modification. But we should use that chart, and then we'll be able to diagnose such conditions. Like it's very important.
And before labeling patient as poor scholastic performance, you should think twice, because when you are mainly dealing with a motor problem, so you have to be very sure when you label patient as, and what forms of poor scholastic. So because according to mother, the expectations may be different. So you have to assess the child. Is it really poor scholastic performance? Yeah, because you are dealing with a pure motor problem. Really.
Okay, I think good points have been highlighted.
And another thing she has highlighted written was DT vaccine. We don't no longer give DT vaccine in government setup. It is always DT at it's always at 1.5 year, 5 years we use DT. So be that, and another COVID vaccine also, because nowadays such children should be offered COVID vaccine.
Yeah, so it was DPT, now it was DT, now changed to DPT, so let's to remember that.
Anyway, I think from the history point of view, please remember in the exam also, rather than going for even the details of the differential conditions, you can prepare this hypothesis. You can prepare some platform that what type of the disorder it is. Whether, I think you can just prepare this background. Is it CNS problem, nervous system problem, or something else? Generalized weakness can be due to so many other reasons. Once you decide probably nervous system problem, try to prepare this background from this information, that is it really this related to which component, central or peripheral. And peripheral also, I think here in this case, quite obvious distinctive some of the points which are there, you can use it. That very classically the problem is specifically the weakness, then the frequent falls, as Dr. Vinu was discussing, difficulty in getting up, then this climbing the upstairs. I think if you have these really points in the complaints, very distinctly you can say that this is some problem related to the muscles. And then you can make it, I would say, generalized statement. It can be the various reasons. It can be some syndromic. It can be even some systemic disorder. As Dr. Sonal was pointing out, can be even the dermatomyositis, or can be some, as I was talking, even some syndromic conditions, or even with some CNS related disorders. But all the things probably as you go in the details of the history examination, it becomes clear. Here I will say, Dr. Anna, is there any condition where even the drugs can create the problem?
So drugs.
Any medicine?
So there is no chronic drug intake or anything in this child?
Which drug can create this problem, this type of the situation, disorder? Which drug?
Very commonly used drug.
And even I will say not uncommon, which I have come across, that for some other condition it is given, prescribed by the pediatrician. Parents are continued without follow-up even by their own, and presents with very bad, I will say, clinical presentation. One of them even having this type of the features. So Anna, are you aware that which drug can cause this type of the clinical presentation? Of course, with some other things will be there on examination, which you will get it. But this type of the disorder is known following some drug. Any idea?
Generalized Generalized weakness can be seen in.
As Dr. Sonal was pointing out, that drug is not, I will say, uncommonly used in pediatric practice. Some of
And
the
even
conditions.
this drug can be used for the treating the condition which we are discussing.
Prednisolone steroids can cause generalized weakness and
Generalized weakness it causes.
This indicates that Dr. Anna is aware regarding the treatment of the condition. And in the exam, if I'm there, I will say that expert is probably informed. And recently, suppose if you have read, it is very good. You will get the scoring. You know, even steroids are known, and particularly the nephrotic syndrome.
High dose steroids. Yeah.
Nephrotic syndrome, many times what happens that the parents, they continue by their own. That's just in the urine examination, some protein, they start the steroids because they know that these drugs works very well. And therefore, without even the follow-up to the pediatrician or nephrologist, they continue for years together. And the child you will get with the very classical Cushing-Coat syndrome and myopathy and short stature and all the features. So it is not uncommon. So I think these are the things. On the contrary, the negative point, you might have mentioned this point, that there is no history of any drug given chronically or for a very long time. On the contrary, that point indicates even to the examiner that yes, you are aware and purposefully you have mentioned and you have at least ruled it out.
Yeah, once in a while, like even for asthma, once in 2-3 months,
Yeah.
I see a patient of chronic asthma receiving steroids continuously,
yes.
and they can present with proximal muscle weakness, myopathy.
proximal muscle weakness.
Yeah.
And even, you know, sometimes the exam, we don't know that where the discussion will take place, which even the steroid preparation, which is very classically will cause more of the muscle weakness and proximal muscle weakness among all the different preparations. Dr. Anna, any idea?
Yes.
You know the corticosteroids, they are classified in different way: short acting, intermediate, and long acting. And they have the different glucocorticoid activity, mineralocorticoid activity, and even the sex steroids. And from all the classifications, very specific even preparation, which is all the steroids can cause this myopathy, but particularly the proximal muscle weakness significantly is known by one of this group. Are you aware of it?
No, sir.
Because, you know, suppose if the candidate is able to answer, the examiner will go at more details. So I think, and that's why the exam, you know, the examiner does not want whether you know the case or not. On the contrary, many times in the lighter way, I always tell the students that today is Saturday, I am giving the case. You see for 7 days this particular case. The same case we'll discuss after the 7 days. You don't mind. But you know, what I mean to say that in spite of all the informations, the examiner wants exactly to assess the pediatrics, not that particular case. So how you are doing, how you are presenting, how you are putting it, and how you are interpreting and analyzing your information. I think that's very, very important.
And it is very important to know the equivalent doses of each steroids.
Yes.
Equivalent doses.
So I think in this type of case, simply if you have to put it interpretation and inference, you can say that 5 years old child has presented with some chronic, slowly progressive disorder. And that disorder seems to be limited to the muscular or locomotor system. And for that reason, the musculoskeletal involvement is more likely. Obviously, there is no any skeletal manifestations. Likely this disorder should be with the muscles. Less likely with this congenital because it will manifest early with normal antenatal and even the birth history and early childhood. Then probably some other disorder which can present late. And therefore, you know, SM and other things you can consider less likely. You can put it in one sentence. I think some rare other presenting, you may even not consider the commonly. And with this, you can say that it can be related to some genetic disorders or even the connective tissue disorders. and therefore dermatomyositis also remains in a differential diagnosis. With this history, you cannot rule it out. And further, I would like to examine the patient and to see that what are the manifest examination findings. Accordingly, I will try to locate that what type of the disorder it is. So I think rather than make it the generalized statements from the history, and somebody is asking the differentials, okay, you can say that these are these. And with the common conditions, I'm considering this one or two. So best way, in short, prepare the hypothesis, prepare some, I will say, background, general, I will say, statement, rather than this pinpoint one or two conditions, because it's very difficult for any clinician from the examination, from the history only. Okay, anyway, I think that's good for the history. Should we go for the examination?
Yes.
Okay, Dr. Anna, now you can share your PPT with this examination.
Okay. Uh, General examination of the child. The anthropometry suggested head circumference 51 centimeter, which is normal for that age. BMI was 14.8 kg per meter square. Posture, he was sitting freely without any posturing. Child is alert, conscious, and cooperative. Vitals of the child: temperature was 98.6, pulse rate 88 within normal limit, respiratory rate 20 per minute, which is regular pattern, and thoraco-abdominal type. BP was 106 over 70 millimeters of mercury, which was within the 75th percentile for the age. Pallor, edema, icterus, lymphadenopathy, cyanosis, or clubbing is not seen. There is no evidence of any neurocutaneous markers, no evidence of any eye abnormalities. There is no temporal fossa deepening, balding. There is no ptosis. The expressions of the child are normal. Calf muscle hypertrophy is present bilaterally. Genitalia and back and spine are normal. According to developmental assessment, presently the patient is up to age. And coming into CNS examination, higher function, patient is awake, oriented in time, place, and person. Memory, reason, and remote memory is intact. He is in a normal mood and affect. Speech, fluency, comprehension, and repetition is normal. Bowel and bladder control has been achieved and is normal. All sensory functions, including cortical sensations, are within normal limit. Cranial nerve examination. First nerve, he can identify the smell of coffee powder with both the nose. And second cranial nerve, the patient is able to read, and bilateral pupillary reflexes are intact. 3, 4, 6, there is no squint. Confrontation test is within normal limit. Fifth nerve, mastication is normal. Jaw jerk absent. Sensations over the face are normal. Seventh cranial nerve, there is no deviation of angle of mouth. There is wrinkling of forehead bilaterally present. Strong eye closure, no drooling of saliva. Eighth cranial nerve, there is no hearing difficulty. The 9 to 10 cranial nerve, there is no nasal twang of voice. The gag reflex is also normal. Coming into superficial reflexes, abdominal reflexes normal. Conjunctival and corneal reflexes normal. Cremasteric reflex normal. Plantaris bilaterally flexor. Tone. Tone is actually normotonic, but there is increased flappability of the muscles, which indicates some kind of hypotonia. And the bulk of the muscles, sorry, uh,
I think, sir, connection is lost or? Dr. Anna, are you there? Probably our connection is lost.
Just asking you.
Yeah, yeah.
And then what happened? Connection lost? So where are you at present? In the conference room? Hello?
Hello.
Yes, yes.
Hello.
Yeah, we are able to hear you.
And I think you can complete your examination, then we'll go for the
Am I?
discussion. Yes, you are audible.
Anna, you are muted. Please unmute yourself.
Dr. Anna, if in case you're not able to project your slides, maybe you can start talking.
Hello.
हाँ बोलो 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 सर बोलो सर बोलो हाँ આવી ગયા છે હમણાં બે લોકો ગયા हाँ અપર રેસ્પિરેટરી हाँ एक्चुअली अपर रेस्पिरेटरी इन्फेक्शन अपर रेस्पिरेटरी इन्फेक्शन છે બાકી તો કઈ છે નહીં બધું બરાબર જેવું છે ચેસ્ટમાં કઈ નથી મીન્સ બાકી બધું નોર્મલ જ છે ઇવન ડાયટ એનો નોર્મલ છે ગેલેરી
Anna, please stop sharing.
સો મારે સર કઈ ચેન્જ કરવાની જરૂર નથી મેં ખાલી ચેરી કોફી
Please stop sharing and start talking on your case.
Yeah, I think if it is not possible, without sharing, she can do.
કરવાની જરૂર નથી એ પ્રમાણે મેં સર બરોબર સમજાય હા હા હા
Hello.
Yes.
Dr. Anda, I think you can stop sharing if it is not possible.
Hello.
Yes, yes, you are audible.
એક્ઝામિન કરી સમજાય અને પછી તેને કન્વિન્સ થઈ ગયા છે બરાબર છે
Vijay sir, please mute yourself.
નહીં નહીં બરાબર બરાબર છે
Dr. Vijay, mute yourself.
Hello.
Develina, please mute
Is
Vijay.
audible?
Yeah.
Okay. Dr. Anna, I think if it is not possible to...
May I continue?
Yeah. If it is it possible to share the PPT? Otherwise, you can do without sharing.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. It's okay. It's not right now. It's okay. Hello. Hello.
Yes.
Hello.
Please carry on. You are audible.
Hello. Uh, may I continue? In the Cns examination, higher patient is awake, oriented, and in time, place, person, memory, reason, remote memories intact. Mood and affect is normal. Speech, see comprehension and repetition is normal. Bladder control is present. Sensory include cortical secretions. Cranial nerve examination, first nerve, patient can identify the smell of coffee powder with both the nose. Second nerve, he can read and bilateral pupillary reflexes are intact. Color vision is also normal. Cranial nerve 3, 4, 6, there is no squinting. Confrontation test is normal in all four quadrants. Fifth cranial nerve, mastication is normal, absent, and sensation is normal. Seventh cranial nerve, there is no deviation of angle of mouth, wrinkling of forehead bilaterally present. Strong eye closure, there is no drooling. Eighth cranial nerve, there is no hearing difficulty. 9, 10 cranial nerves, gag reflex is present and there is no nasal twang or dysphonia. Abdominal bilaterally present, conjunctival and cord present, plantar reflex bilaterally flexor. Tone, there is normotonia, but there is increased flappability of muscles, which suggests of some amount of hypotonia also. And then bulk, generally the bulk of muscles seems to be reduced symmetrically. Valley sign is positive, that is infraspinatus and deltoid muscles seems to be hypertrophy. Calf muscle hypertrophy is present, and DTR, it is plus in all four limbs. Power 4 by 5 in the proximal muscles and 5 by 5 in the distal muscles in all four limbs. Gait, the child is having waddling gait. Then Grover's sign is positive. There is no signs of meningeal irritation. Romberg sign negative. Finger to nose test normal. Finger test normal. No rebound phenomenon. No diadochokinesia. No involuntary movements. This is the video of the child.
Anna, you can continue talking as we are not able to see the video.
Are you able to share the video, Dr. Anna? I think video may not be possible.
So, other system examination. S1, S2.
Dr. Anna, you are not audible at all.
There are no murmurs, no JVP elevation, no S3. Per abdomen, it is soft, no hepatosplenomegaly respiratory pattern, and no adventitious sounds. Hello.
Okay, go
Was I
ahead.
audible, sir?
Go ahead. Yes, yes.
Sir, hello.
Yes.
So CNS examination is over, and at the end I had put a video of Gover's sign, and then coming to other systems may it is CVS S1 S2 present, no murmurs, no JVP elevation, no S3 per abdomen, it's soft, there is no hepatosplenomegaly, and respiratory systems there is no abnormal respiratory pattern, RR is normal, and there is no adventitious use of muscles, there is no crepitations, no added sounds. And to summarize, we have after the history and detailed examination, it is an insidious onset, slowly progressing, proximal, symmetrical muscle weakness with normal distal muscle function, with no sensory or cranial nerve or bowel and bladder involvement, isolated gross motor delay, pure LMN motor weakness, proximal disc more than distal, with Gover sign positive and reduced proximal muscle mass with calf muscle hypertrophy, waddling gait positive. This is my summary, sir.
Okay. I think now already you have stopped sharing. So whatever these connectivity is available, we have to continue to talk. Because
Sorry,
probably sharing the PPT will not be possible. Anyway, I think what were the positive findings on a general examination? Let us come in this way. What you got on general examination? Dr. Anna, are you?
In general examination.
Okay.
Huh, sir?
Yes.
Sir, in general examination.
Please go ahead.
Sir, am I audible?
Yes, yes.
Sir, in general examination, the only positive finding I got was the calf muscle hypertrophy and the valley sign. No other positive findings were there in the general examination, sir.
On the vitals, what specifically you will check purposefully? Suppose in this patient it is there or not, but what points you will try to note on the vitals particularly of such patients?
Sir, respiratory rate and single breath count should be taken because it is a progressing muscle weakness which can lead to respiratory muscle paralysis. So we should check the respiratory rate and single breath count of
What
the
is
patient.
what is the single breath count? How will you do?
We have to ask the patient to count from 1 in a single breath while he is expiring. And if it is less than 15, if the patient is not able to count less than.
How will you ask the person or the patient to do that test so that you can interpret it properly? If the patient does not know the single breath count, you will have to explain the patient.
We have to ask him how far in a normal speaking voice he have to do after a maximum effort inhalation. The patient has to count from 1 in a normal speaking voice without taking the next breath.
Right, and then what will be your interpretation?
If it is less than 15, it is impending respiratory muscle failure.
Right. Can you?
It should be more. It should be more.
Can you mention some conditions where this single breath count will be useful?
So mainly it is for acute conditions like Guillain-Barré syndrome, where we can assess the respiratory muscle paralysis and need for ICU admission and emergency therapy, mainly there. And then we have it in snake poisoning, again an acute condition where we should assess for neurotoxic symptoms. And next we have myasthenia gravis also, when it presents acutely to rule out respiratory muscle issues. And this is actually a chronic kind of condition. In this, SBC being involved is usually a late sign, but we should check the vitality of the patient respiratory muscles through that.
What specifically will check in pulse in this patient? Anything which you should be very vigilant when you're examining the pulse?
So in these, there is chance of cardiac failure due to cardiomyopathy in these patients, but that is also a late sign. So in CF, there can be.
Dr. Anna, I do not know that when the child is going to develop the problem. Late or early, I don't know. If I examine, and even to my surprise, I may get even early also.
Yes.
So the point is that I should know only that what I should examine, and then I will go for the interpretation. I cannot fix up from the, I will say from the beginning that this is not expected, it should not be there. But to our surprise, sometimes it may be early also. Can be. The only thing that what you will be vigilant to see the pulse in such patients.
Yes. And we should also check for the JVP. If there is any JVP elevation, that is also suggestive of any cardiac failure.
When you will check the JVP? In which patient? Every patient?
No.
Suppose if I am in the round, simple forget regarding the condition of the patient. I am just taking regular round of the patient. And I am sure that hardly we check for the GVP except in very specific patients. So what is the situation of the patient? Right. Where I will go for the GVP and then I will interpret.
Failure, sir. If you are suspecting right heart failure, sir. So if there is any shortness of breath, if there is any bounding pulse, and if there is S3 gallop rhythm and tender hepatomegaly,
JVP will be present in right-sided cardiac failure or left-sided cardiac failure?
Right failure, sir.
And then what will be the other presentations or manifestations before the JVP?
Tender hepatomegaly, pedal edema, sir.
Yeah, pedal edema will be there. Hepatomegaly will be there. Right. And then you will check for the JVP. How will you examine for the JVP?
So we have to first make the patient sit in a 45-degree inclination. And then we should have two scales in our hand. And we have to we have to isolate the pulsation of the jugular venous pulse, and we have to make the patient look towards the opposite side and at the 45-degree inclination, and we have to isolate the two heads of the sternocleidomastoid, and in between we have to find the pulsation, which is more seen than felt. So once we see it, we have to mark the point with the scale, and then with another scale we have to measure the height of the scale at which the mark has been pointed. So the height of the thing from the sternal notch will give you the exact centimeters of the JVP.
Anyway, at least it indicates that you are aware of it. Here we cannot ask for the demonstration, but sure that the way which you are described, it indicates that you are aware of it. And the point is, that any such questions can be asked, and then we should be prepared. I think here you should check for the pulse rate. Is there any tachycardia or so? Sometimes even that can be the arrhythmia also, or something like that. So you should examine the pulse. What can happen with the blood pressure in this patient? Any problem with the blood pressure?
Dilated cardiomyopathy can they can go into hypotension, sir.
Can cause? I think some questions come unexpected. Not necessarily even the abnormal findings. Anyway, my point.
Hypotension. There is chance of
Doc-
hypotension.
Doctor, now what was my point? In the examination, the discussion can take place in any point. The only thing examiner is interested whether are you aware of it, whether are you able to perform it properly or not. Anyway, examination, other points you said that the calf muscles were prominent. Is it?
Yes.
And what another thing you mentioned the positive finding on examination, general examination?
Valley sign, sir.
What is that valley sign? I have not heard the name
Valley
even.
sign. Valley sign.
Where do you see the valley sign? What is that valley?
So it is infraspinatus hypertrophies, and in between these two muscles near the scapula you have a depression, like a valley between two mountains. So that is also again because of muscle hypertrophy seen usually in dystrophy, muscular dystrophies. So that is there in this child.
Why there is hypertrophy of the muscles? Once we are talking that there is the problem of the muscles, why there is hypertrophy?
So it is because of hyaline and hyalinization and hypereosinophilic fibers in the.
I think that they will get
muscle fibers.
Doctor Anna, please. They will get in the, I will say, histopathology, which I don't know. As a clinician, just I want to know that why there is a hypertrophy. On the contrary, we are discussing that the muscle is getting the damage. If there is damage, why there is the hypertrophy? And one side hypertrophy, another side there is a loss of some functions. So what is it? It's difficult to explain. You have to explain me. Really, it is confusing to me. Dr. Anna, are you there? I think this net is helping her. I think you are back. Is it right? Today, I think net is a big issue. I request the students in the future that check in it. Okay, come on.
Yes, sir. So this is a dystrophin protein is not. If it's talking about muscular dystrophy. Yes, sir. No, sir. Sir, am I audible?
Yes. Please carry on. We are able to manage.
Yes, sir. Basic muscle fiber architecture resulting in hyalinization and fat tissue deposition. So it is actually muscle fiber being replaced by adipose tissue, giving a pseudo hypertrophy picture in these.
In which person you will get the real hypertrophy?
Children, which can happen.
Dr. Anna,
in many muscles, including gastrocnemius, there can be pseudo hypertrophy.
Dr. Anna, I will request you in the exam also, address the question which is asked to you.
Pardon, sir?
Always in the exam, answer the question which is asked to you. Right? It will create a good impression. Here I ask, okay, as you said, the pseudo hypertrophy, but is there any condition where the real hypertrophy of the muscles should be there?
So, pardon, sir, once more, can you please?
I think here in this condition you are talking that there is the hypertrophy of the muscles, but it is the pseudo hypertrophy. My next question, is there any condition where real hypertrophy is there?
Anna, can you differentiate hypertrophy, atrophy, and dystrophy? Then you will be able to answer sir's question. So, hypertrophy, where do you get? What is hypertrophy? What is atrophy? What is dystrophy?
I think again, Sonal, her connection is lost probably, so she is not able to listen our question.
I think we should have
So
two.
it's dystrophy.
I think Anna, another thing I will suggest you, can you join on the phone, your phone? Probably the phone will work. This laptop connection is not working.
So
Anyway, I think her connection is lost.
no, sir. I do it with laptop. My phone hung. My Wi-Fi is also not. That's why. Hello, sir. Hello, sir.
So,
Yeah.
Anna, you can do one thing. You can join from your phone only and switch off your laptop.
Dr. Nihal, Dr. Nihal,
Issue is my phone is hung up. As we started.
Dr. Nihal, my request to all of you, I have some emergency of one patient, so I have to go to attend the patient. So please, you'll have to pardon me. Sorry.
Yeah, it's okay, sir. It's
So
okay.
please, you carry on
Both the
because
experts will.
because I got the phone call frequently and that patient is I will have to attend it. Please.
Yeah, sure, sir.
Sorry.
Anna, you can switch over to your phone and both the experts will carry the case for further ahead.
Ma'am, my phone is not working. That is the main problem. Like Wi-Fi is going hung up because of the phone only.
Your mobile data is not working.
Now you can join with the mobile.
No, ma'am. Mobile data is the issue, sir. Like laptop is okay.
And now you are in the hospital?
Yes, sir.
Get someone else's phone and yeah, that will be fine.
You can join with
Now
from
I'm
other.
ma'am, I am using my friend's phone right now.
If any other resident is there nearby, you can join with his or her phone.
Friend's phone. I am using my friend's phone. I'm using friend's now. Audible right. Hello.
Yes.
Yeah.
I'm audible right now. I'm using my friend's phone.
Yes, we are waiting for you. Please join through your friend's phone.
Yes, ma'am. I've joined using my friend's phone. I hope it's okay now. Hello, ma'am. Hello. Hello.
Yeah.
And it's difficult to hear you properly. So is it possible to join through somebody else's phone?
Yes, ma'am. I will.
Yeah, now we are able to hear you properly.
Try to speak something. Okay, continue with your case discussion. No, Anna, we are really not able to hear you anything.
Anna, you can join with someone else's mobile.
Yes, please join with somebody else's mobile.
I think at 7 o'clock we have to finish, ne?
Yes, ma'am. We will be finishing before at least 5 minutes before the 7 o'clock.
Yeah, so
And,
less time now, only less than 20 minutes.
So for the next time, I will also remind them to be in a good network coverage.
Yeah,
area.
and 4-5 students from the other institute, other colleges or the same college, backup plan. I think we can do that.
Yes, they need to. So I will tell them everything 1 day ahead. This is the first time we are facing this much of the problem of NET.
Yeah.
Hello.
Yes, now it's proper. Go ahead
Hello.
Anna, and answer Sonal ma'am's question.
Ma'am, I hope you asked the question, what is the difference between real hypertrophy and pseudo hypertrophy? So in pseudo hypertrophy,
dystrophy, yeah.
Atrophy is actually wasting of muscles, which will be there will be visible loss of bulk in atrophy, while in real hypertrophy there will be increase in the bulk of muscle on examination by inspection and palpation with a normal tone. But in pseudo hypertrophy, the difference is there will be on inspection the muscle might seem to be hypertrophy, but on palpation there will be no actual muscle mass hypertrophy, and also the tone will be low, which is most commonly seen in this group.
And can you give example of each condition?
For dystrophy, pseudo hypertrophy, there are many conditions like even all kinds of muscular dystrophy, and then we have our SMAs. Then we have.
Okay, do you get dystrophy in SMA?
Pseudo hypertrophy, I'm telling you.
Okay.
Dystrophy is actually pertaining to
What
protein.
is the full form of SMA, Dr. Anna?
Huh?
What is the full form of SMA?
Spinomuscular atrophy.
Yeah, so you
it is atrophy.
have, yeah, so it is not pseudo hypertrophy or dystrophy. You get atrophy. Yeah.
Okay. And other pseudomuscular atrophy, hypertrophy, you can see in hypothyroidism, where there is Kocher syndrome, in which you can find.
In which condition in hypothyroidism, where do you get exactly this kind of thing?
Kosh's it is
So what is
Kosh's
that?
syndrome.
Yeah. So you don't always get in hypothyroidism, ne? So
No,
when
ma'am.
do you get usually? It's a
It is
long-standing,
smaller,
yeah,
smaller.
long-standing hypothyroidism, not treated.
No.
Yeah. So in that condition,
Long-standing, and also it should be small children. Like in bigger
yeah.
adults, you cannot see. Adolescents, you cannot see that.
Yeah. And what about hypertrophy? Sir's question, last question was that where do you get real hypertrophy of the muscles?
Muscle, real hypertrophy with increase in muscle mass.
Yeah. So it's very common nowadays.
Athletes and
Persons, those who train hard in gym and
yes.
lot of weightlifting and all, where you have athletes, where you have this kind of hypertrophy of the muscles.
Yes. Use of antibiotics.
Yeah. Another thing I wanted to tell you that anthropometry. Your weight is very important. You mentioned BMI. So
Yes.
what will you do for the children of 5 years? He's 5 years, 6 months, ne?
Yes, ma'am.
Yeah, so you have to take BMI. Now, how do you know that if BMI is normal, overweight, obese, or underweight? So if you have the
according to Asian standards, this person is coming under underweight category.
no, you cannot decide like that. You have to plot it on the charts.
According
like,
chart,
yeah, it's not
according
like,
to the chart.
Yeah. So you have to show the chart also, and according like usually in children it is not according to like that about
standards.
Yeah, about the standard the child is normal and about this standard overweight or obese or something. You have to plot it on the chart and you have to see where they fall, because it is very important. Why it is very important to know about the BMI of the child?
Yes. According to the chart, he is having thinness, ma'am. Mild thinness
so
is
why
present.
it is important? Why it is important to know about the BMI of the child with this chronic history, which is involving primarily the muscles?
Ma'am, in the nutritional status, it gives us a history about nutrition. Gives a marker.
Yeah, so they are all indirect markers of other system involvement, basically. Knowing about the BMI. And yeah, another thing you have mentioned is whatever I have heard from your presentation is that power of the muscle. In distal muscle, it is grade 5. And proximal muscle, it is grade 4. That's I think that's what I have heard. Eh? Yeah. So usually, how do you describe the power in children? What do you usually do?
According to MRC grading, ma'am. So we have done it. I have done it with each and every. I have checked shoulder adduction, and
you should mention in detail about that.
Okay.
Yeah.
Yes,
Powers at the different, like flexors of hip, extensors of hip, whatever, like all the groups of muscle according to the function you have to mention. Yeah? So because it may be different. Yeah.
And see,
and upper limb and lower. Yeah.
Here one important thing is like many a times students, they are confused with the tone and power. So tone and power doesn't go hand in hand. Like say when tone is less, power has to be less. It's not like this. Power, when tone is less, power can be 5 like. And when power is less, tone can be normal also. So this is very important. All of you, Anna, you should remember, and all the residents should remember this.
Okay.
And what about, you mentioned normotonia to hypotonia. So what do you mean?
Ma'am, that I was actually confused because tone on examination against passive movement, it was normal. But the muscles had increased flappability. So that is suggestive of hypotonia. So that is why
because the muscles are flabby?
Yes, ma'am. Flappability was increased, like they are very flabby.
Yeah, so which are the muscles they are flabby? All the muscles, or there are selected group of muscles?
Mainly the large muscles, ma'am, the quadriceps and the limb girdle muscles, ma'am, mainly. Proximal muscles are flabby.
Quadriceps and?
The girdle muscles, mainly gluteus, they were all flabby, ma'am.
Okay, so how can you explain that?
That might be because of loss of muscle tissue that is going on.
Okay, and you mentioned that bulk was reduced.
Yes,
so
ma'am.
At one point you are telling that it is hypertrophied muscle, and bulk of the muscles have increased, and so at one point you mentioned about bulk reduced also. So which group of muscles the bulk is reduced?
Mainly girdle muscles, ma'am. In this patient, the gluteus region and even the biceps where bulk was reduced. Actually, the hypertrophy was only in the calf muscle, gastrocnemius.
So what do you think may be the cause of these muscles where you have found out bulk reduced? What do you think is the cause?
Because in this child there seems to be more involvement of proximal muscles, and the wasting has started from the proximal muscle.
Can you tell the other causes like of weakness, or where the bulk generalized reduced in the bulk of muscles occur?
Generalized reduced muscles, most commonly I've seen cerebral palsy with disuse atrophy. Because of disuse atrophy, you have muscle mass loss in all proximal and distal
Any other
muscles.
condition where you can find generalized reduced in the muscles, bulk of muscles?
Malnutrition, ma'am. Severe acute malnutrition, generalized muscle mass.
So malnutrition. So is it because the child is undernourished, and that's why the child is having muscle bulk reduced?
But it is not it is not equally distributed, ma'am. Whatever bulk reduction that I've seen in this child is not equally distributed. But in Sam, it has to be equally distributed. But in this child, it is unequal, and the child does not have any other features of malnutrition in general examination. And even his BMI plotting was just borderline undernourished, and it is not that kind of more than -3 ST is not there.
Okay. So what is your inference from the history? From the history and examination, like what can be your differential diagnosis?
Ma'am, I'm dealing with a chronic insidious onset kind of motor weakness, which I guess is after examination, I feel it is element type of weakness. And it is most probably isolated to proximal muscles more than distal muscles, and which has progressed over 10 months of time period, and without any nerve involvement or bowel involvement or sensory loss. So it is some kind of muscle pathology is happening in this child, which is having an onset of 4 to 5 years of age, and which is progressing.
Yeah. So what are the common differential diagnoses?
Ma'am, my comment, and the Gover's sign was positive, Adling gait is present. So it is again pointing towards a proximal muscle involvement. So my differential diagnosis will be, first of all, it will be muscular dystrophy, and most commonly Duchenne's or Becker's. Duchenne's because it is a male child, and Becker's because it is not very fastly progressing, but we can see it only after genetic testing. And my third differential will be myopathies, which is again less likely because of onset of age. And my fourth diagnosis is late onset spinal muscular atrophy, again, which is a very rare condition. So I guess it is most probably dystrophy, muscular dystrophy, with all the signs that I've seen in this patient.
Okay. So why did you say that it is a lower motor neuron involvement? What are the points favoring?
There are no long track signs. There is no spasticity. There is no plantar extensor, and there is no abnormal movements. So less likely to be a UN, less likely to be a UMN lesion, ma'am.
Okay. So
And there is no cortical signs also.
whenever such child comes to you, now what will you do? So this is, you have put a probable diagnosis of muscular dystrophy. Now you want to investigate the child. What will you do?
I should go for an electromyogram because I am suspecting a muscle pathology, and muscle biopsy to rule out like autoimmune conditions.
Why do you want that? Why do you want to go directly to electromyogram? And
we should do a nerve conduction study also, ma'am, because neuropathy is also likely.
Any other investigation you would like to do which will definitely help you to confirm your diagnosis, which is very important, yeah?
Yes. CPK, creatinine kinase.
So how does a CPK will help you in differentiating the, definitely help you in the diagnosis of Duchenne or muscular dystrophy?
Ma'am, mostly in almost all the muscular conditions, myopathies, you have an elevated CPK. But
No. You be specific. Where, in which condition? Muscular dystrophy, what will you be your CPK values? And in myopathies, what will be your CPK value?
In muscular dystrophy, it will be more than 1,000. And in
not always more than 1,000, but it is elevated many times. What is the normal like CPK value?
Hello, ma'am.
Dr. Anna, what is normal CPK value like? Can you tell us?
Ma'am, it is maximum 100. It should be less than 100 to 150.
Yeah, so it is elevated many times in dystrophy. What happens in myopathy?
Myopathy also, it will be elevated, ma'am. It will be more elevated than, it will be 10 folds from the basic.
So in which condition it is more elevated, dystrophy or myopathy?
More elevated in dystrophy.
No, it is in dystrophy. Yeah. So CPK value is more helpful for the diagnosis of dystrophy. It is high. In myopathy, it may be normal or it may be just mildly elevated. Yeah. Now what next? You will have CPK value which is more than 2,000 or something like that. Yeah. So now what do you do?
If you want to go,
yeah, because now Dr. Veenu ma'am will come in picture.
If we have to clinch the diagnosis, we have to directly go for a MLPA.
Yeah, so Dr. Veenu ma'am, can you give us the,
I just want to get back to the history. So in future, just keep in mind, you should also draw a small family tree. To start with, you may find it difficult. It hardly takes about 2 minutes time to ask about how many siblings, especially the mother's side history becomes very important when you have a 4-year-old child with muscular dystrophy.
This patient has got an 8-year-old elder sister. She does not have any symptoms, and maternal uncle is also.
But you should make a pedigree chart. That will be better.
Okay,
and the siblings of the mother, especially if the mother is having any sisters or brothers, are they okay? And their children, the sisters' children, if they have any sons, what is their age group? This history is very important.
Any death in early age death in maternal uncle or something like that.
Yes.
And are there any ladies on the mother's side, including the mother who have had an unexpectedly early death? So usually the maternal carriers may have dilated cardiomyopathy. They may not have muscle weakness. They may die of cardiomyopathy after 35 years of age or so. So history of any sudden deaths, history of any muscle weakness on the maternal side becomes very important. And even on the paternal side, it is important to take history of muscle weakness. Why is it important? Because in your differential diagnosis, other than Duchenne's muscular dystrophy, you have multiple types of limb girdle muscular dystrophy.
Yes, ma'am. उसमें और there is chance of
LGMD
automuscular dystrophy.
and LGMDs, you have several types of LGMDs. Some of them are childhood onset, some of them are adult onset.
Adult onset.
They could be autosomal dominant, they could be recessive. And again, consanguinity of parents become very important. Sometimes there may be this anticipation in the family tree. So Emery-Griffiths, let's say if in the father, if it is quite adult onset, after 30 years, in the next generation, it could be earlier onset. So it's very important that you take at least 3-generation family tree. And generally, if you're suspecting neuromuscular disorders, it will be good if you examine the parents as well. If at all they're having, early signs of any muscle weakness. And coming back to this,
Vinu ma'am, can you give us now, CPK has already come high. We are very sure about diagnosis of DMD. Now, how to go further?
So moving on to the genetic testing, if you are suspecting Duchenne's muscular,
it must in all patients. Yeah, so that's what. Yeah.
So if you top the differential diagnosis based on CPK, usually it is 100 times elevation or so. It will be like 8,000, 10,000. So you are fairly sure with the age of onset, it's mostly DMD. So you will be testing for the gene called dystrophin gene. Now, testing this gene is a different technology, and testing rest of the genes causing other muscular dystrophies is a different technology. So your differential has to be strong enough. Once you suspect DMD, you should do a test called multiplex ligation probe amplification, called as MLPA test, wherein you're looking at deletions and duplications in the gene. Because if you have 100 children with DMD, 65 to 80% of them will have deletion or duplication. Deletion is the most common mechanism. And rest, 10 to 20% of them may have point mutations. So once you do MLPA and you find a deletion, you're fairly sure that this is mostly Duchenne's muscular dystrophy. Let's say your MLPA comes normal, and that happens only in less than 20% of the cases, in which case you will have to sequence the gene. That is, you're checking every alphabet in the gene to see if there is any sequence variation or point mutation in the gene, and that's very rare. So once you have the diagnosis of the child, the next step would be to understand, is the mother a carrier? Why are you checking the mother? One is the implications to the other family members. Is there a recurrence risk? And number two, if carrier mothers are at a lifetime risk of developing cardiomyopathy. So essentially, when you do a CPK in the mother, if in the child the elevation of CPK is 100 times, in the mother it may be less than 30 to 40 times elevation in CPK. Not all times it is going to be elevated in the mother. So essentially, in carrier mothers, we do one screening echo. Once they cross this 30 years of age, and we do the same MLPA test in the mother in order to see if she's carrying the same deletion. Now, why is that? If the child carrying the deletion has the symptoms, but the mother carrying the same deletion not having muscle weakness, can you explain what is the reason, Dr. Nanna?
Mostly women have it is unless there is lionization and in Turner syndrome. Otherwise, there are 2 X chromosomes in all women. So if one gene is it is an X-linked recessive disorder, so the other gene will be functioning. So mostly there will be more than 50% of dystrophin gene production. So that is why they will not be symptomatic.
Correct. Yeah. So carrier mothers are usually asymptomatic. At the most, they may have cardiomyopathy, and very small fraction of carrier mothers may have mild symptoms. And exceptional cases, they may have muscle weakness only if they are Turner syndrome. But again, Turner syndrome is quite rare. Adults with Turner syndrome and having children is quite rare. And then we have uniparental disomy. These are the scenarios where females can manifest with childhood onset of muscle weakness, having Duchenne's muscular dystrophy, and then lionization, definitely. And essentially, if the mother is a carrier, cascade screen to the extended family members can be offered. When I say cascade screen, If the mother is having other siblings, the female siblings, they could be offered carrier screen. Of course, every time you offer a genetic testing, it's very important to have pre-test genetic counseling, because you cannot enforce any genetic testing on any individual other family members unless and until you offer pre-test genetic counseling, make them understand what is the benefit, pros and cons and implications. And the other female carriers and their offsprings, depending on how old the kids are, probably you can extend the screening to them. And in case of this child, generally we don't offer screening to female siblings who are quite young, because there's no implications to treatment or unless and until they reach 18 years of age. So that is one thing. And apart from deletion, how do you check the point variations? Either you can offer a test called Sanger sequencing, or we have the next generation sequencing, that is the exome test, wherein this dystrophin gene is part of many thousands of genes that would be studied.
Like what are the indications of whole exome sequencing in case of DMT?
So in DMT, the first line of testing is definitely not whole exome sequencing. First, you need to do a MLPA. If MLPA is negative, then you can go in for a clinical exome or a whole exome testing. Now, why are you offering that is that because your differential diagnosis could still be a DMT, or it could be other muscular dystrophies like limb-girdle muscular dystrophy. So when you're offering an exome, you're covering other genes that are implicated in limb-girdle muscular dystrophy, or could it be Emery muscular dystrophy, or those few hundreds of genes that cause different types of muscular dystrophy. So in one shot, you're trying to study all the genes and try and get a diagnosis. Now, when you do a genetic testing, either you may have a diagnosis be established, or you may get something called variant of uncertain significance. That is, you're certain that there is a variation in a gene, but you're uncertain about whether this change in the gene is responsible for this type of muscular dystrophy. In which scenario you will be doing reverse phenotyping, trying to get back to the child and assess for symptoms related to that particular child, and also probably look into whether you can offer some sort of functional studies. When I say functional studies, it means, let's say you get a dystrophinopathy gene mutation, probably your CPK is suggestive of it, then more or less your diagnosis is close. And definitely when you do a muscle biopsy and immunohistochemistry, probably it would be diagnostic. If you have a calpainopathy, then or the other different types of muscular dystrophy, you can offer muscle staining accordingly to look at the protein in the muscle and support the diagnosis. So your uncertain variants become a definitive diagnosis after muscle biopsy results.
Yeah,
and then it is included in the catalog also, no? In their genetic catalog they maintain, and that whatever the changes are seen in the gene, if it's not there in that, even though when it has come with your FLPA or next generation sequencing, then it is included in the catalog of the diagnosis of Duchenne or dystrophy, that this is the gene which has been found out, and then henceforth whatever the patient present with that particular gene likely to be having then Duchenne muscular dystrophy.
Yeah, and Dr. Anna,
Yes,
ma'am. Manage start managing this case.
Ma'am, I'm interrupting here. We have already crossed our time of 7. We can take few questions which are there from the other students from YouTube. So any of the experts, please enlighten. One is, if the child cannot speak or doesn't know how to count, then how to assess the respiratory muscle weakness?
Yeah, so in that condition, what you can do is respiratory muscle, you can do that diaphragm, test the diaphragm, and you can test even the intercostal muscles also. Like you block the muscles, diaphragmatic muscle, and test the function of the intercostal muscle. You block the ribs and you test the function of the respiratory muscle, diaphragmatic muscle. Okay, so this is how you can test for the respiratory muscles. Yeah. Very small child, and you can even see from the examination also, because child will have a seesaw type of respiration. Child might have, if there is a chronic respiratory problem, child might have Harrison sulcus. Okay, so this is kind of things you can see just by the inspection also.
And especially in children with Duchenne's muscular dystrophy, of course, echocardiography and recent guidelines, even cardiac MRI is an indication to pick up early changes of cardiac involvement. And we do have modifying drugs like Covarcil to start off for these kids. And definitely polysomnography also falls into the surveillance investigations in order to pick up sleep apnea in these children.
Sleep apnea.
The second question from the audience is, if single breath count cannot be
Dr. Nehal, I think we are unable to hear you. So I'll just read out one of the questions probably relevant to my subject. Can amniocentesis or antenatal testing be done to detect Duchenne's muscular dystrophy? So Duchenne's DMD is of course a monogenic disorder. It is possible to diagnose prenatally by doing either chorionic villus sampling, which is nothing but we take a bit of placenta, and this test is done between 11 weeks to 13 weeks in pregnancy. And or we could do amniocentesis, which is usually done 16 weeks onwards, wherein the fluid around the baby is taken out a little bit. Essentially, the chorionic villi sample and amniotic fluid both contain DNA of the baby. And so we prefer one of the invasive testing. And on this DNA, we offer testing for the dystrophin gene, depending on what the proband child has. And most times these results take about 3 to 4 weeks time. And we could confirm with good accuracy whether the fetus is affected with DMD or not affected with DMD.
And what about the screening of child sister? Yeah.
So screening of child sister, generally we don't offer for young children. If they're not symptomatic, it's not indicated. Probably as the child sister grows into an adult, because there is implications to surveillance for cardiac involvement in an adult female carrier. Probably once the girl crosses 18 years old, then probably we could offer them pre-test counseling and then offer a screening test in the child sister.
Yeah, and because she needs to be counseled before, she
Yes.
needs to know that whether she is a carrier or not.
Correct.
Before marriage.
Yeah.
Now, what is the last question? What is the status of gene therapy at present for DMD?
So we do have gene therapy, and in several centers in India, gene therapy has been, exon skipping as one of the treatment modality, the etelopersin has been developed. And we do have in Bangalore where this particular therapy, exon skipping therapy, is being taken care of, and few other centers. So essentially what we are doing, what is Duchenne's muscular dystrophy? It's an out of frame deletion. The amount of dystrophin protein that is being formed is very less. And hence there is severe involvement of muscle weakness, and most times they don't, untreated children, they become wheelchair bound by 14 years of age. Whereas in Becker's muscular dystrophy, they're mostly mobile after 14 years of age. They're not wheelchair bound. Clinically, this is a differentiating factor. But at molecular level, when you do a genetic testing, there are two types of deletion. One is in-frame deletion, one is out-of-frame deletion. Generally, in in-frame deletion, there is some amount of dystrophin protein, fairly good amount of dystrophin protein that is being produced, and hence they have less involvement of muscle weakness. So in Duchenne's muscular dystrophy, it's an out-of-frame deletion. So when I say we have therapies like exon skipping, we are trying to convert the out-of-frame deletion into in-frame deletion. That is, very less amount of protein is being converted into a DMD is being converted into a BMD phenotype, that is Becker's muscular dystrophy. That is, more severe disease is being converted into a less severe disease. So it's not that we are completely curing the disease, we are kind of shifting the domain from a severe to a less severe disease. And probably we have limitations of time right now to explain what is out of frame, in frame. We have images wherein usually 90% of the time, the in frame, out of frame is applicable to assess whether it is DMD or BMD. But in 10% of cases, this rule may not be applicable. We have seen that even in frame deletions have had severe phenotype like Duchenne's muscular dystrophy. Probably I would have loved to have some more time to have a discussion on this. So to keep it minimum, we need to remember what is the rule of frame, what is out of frame, what is in frame, and how do you differentiate between Duchenne's and Becker's muscular dystrophy.
When this holds true for all the such genetic disorders, wherein the
No,
gene therapy is
this
available.
Gene therapy. So among all the muscular dystrophy, right now the therapy is being offered for definitely for spinal muscular atrophy, SMA, where again we are trying to convert a more severe disease into a lesser severe disease, where exon 7 deletion is seen in that particular condition, and we are trying to include the pseudogene exon 7 in order to make it a better protein. Whereas in Duchenne's muscular dystrophy, again the disease mechanism is deletion. So we are trying to play around the deletion in order to include the missing bits of the gene so that a better amount of protein is being produced. We cannot completely cure the disease. We are trying to reduce the severity of the disease. Whereas for other muscular dystrophies, there are hundreds of muscular dystrophies. Right now, we don't have therapy. This is only being developed for muscular dystrophies where deletion is a mechanism of gene mutation.
Okay, so
I think.
thank you very much, all the experts, the student who is presenter, Anna, and thank you, Vijay sir. We had a lot of internet today, but still we could complete everything. And in the last, Vinu ma'am has given us a lot of light towards how to do for the screening, what are the for that. Thank you very much. I need to stop this discussion today at this point. So we are now stopping our Zoom meeting for. Thank you very much.
Thank you, Dr. Nehal.
Thank you.
Thank
Thank
you,
you,
madam.
Dr. Anna.
Thank you, ma'am. Thank you.
Thank you.
So Dabelina, you can stop streaming. Okay. So we can leave now. Thank you.
Thank you.